all the aspects of the regenerative medicine, including the science, evidence, and the clinical applications, and the role of ultrasound. Today, I'm just going to share a brief snapshot of the role of ultrasound within the regenerative medicine. Before I go and do that, I just wanted to give a bit of a introduction, my disclosures. I have quite a varied job profile description, you could say. Predominantly, my work is in private sector. I still do a tiny proportion of the local NHS work in UK in the radiology department, doing ultrasound guided procedures, one session a week. The remaining 90% of the times I spend my time in my own clinic in Kent, which is called Kent Musculoskeletal Clinic, which offers one-stop solutions for all the musculoskeletal problems. And I also work in Harley Street, Central London, in this clinic called the Regenerative Clinic, which offers all wide spectrum of regenerative joint preservation techniques for managing all sorts of musculoskeletal and sports injuries. Apart from clinical part, my passion is teaching and training. I split about 30% of my job description in teaching and training. I do that in a wider platforms. I teach at Canterbury, Christchurch, at postgraduate. Okay, let me say, yeah. Sorry, I'm just going to, yeah. Canterbury, Christchurch as for the postgraduate musculoskeletal ultrasound program. And I also work as a consultant for Arthrex facility in the Munich, where I teach for their ACP, PRP system, including peripheral joints, ultrasound guided injection of peripheral joints, and also the spine. And I also work along the Sonoskills, which is a European company led by Mark Smith, who deals with ultrasound education for the primary and secondary. And then I'm the director and lead trainer for the musculoskeletal ultrasound guided injection for that. And apart from those, I was fortunate enough to spend some time with this gentleman here in the middle, Dr. Lev Nazarian, who is a renowned MSK radiologist from Thomas Jefferson. I was fortunate enough to go and spend some time with him, share experience and his wisdom, especially within the interventional side of musculoskeletal. That has helped me a lot in the beginning of my career. Apart from that, I also offer a fellowships and a program director for musculoskeletal medicine and musculoskeletal ultrasound, where in Central London, where I work in the regenerative medicine. This is what I do. I do pretty much about 100 procedures a week. That varies from the steroid injections to stem cells to PRP injections and the complex procedures like hydrodissections to barbotage, osteitis pubis, and spinal injections. So that's where my passion is. And this is my special interest with the orthobiologics and ultrasound guided spinal injections. So, as I mentioned, right. In recent years, there is a significant progress has taken place in the area of regenerative and cellular-based medicine. Using the patient's own cells and growth factors to heal the damaged tissues and promote tissue regeneration has become an attractive option for both the clinicians as well as the patient. It's been widely used over the traditional approaches like non-steroidal anti-inflammatories or the steroid injections. So what are these regenerative therapies? So I'm just going to briefly touch base. One is the BMAC, bone marrow aspirate concentrate, where the bone marrow of the first patients has been taken and that's been processed and as either centrifuge to concentrate it and to gain the growth factor, the stem cells from that BMAC, and then inject back into the patient's joints and soft tissues. This is quite popular within US, and then even in Europe and even in our practice, we tend to use this BMAC on the younger age patients compared to the older patients. And then another product within this regenerative or orthobiologist product is the mesenchymal stem cells. So more recently it's been renamed as a medicinal signaling cells. That's what the current name stands for, the adipose derivative. These are all, you take patients' own fat, process them with the minimally disrupted systems, and then you get these what we call as peri-sized pure lipogems, and then we inject those back into patients' joints and soft tissues to help and heal and promote the healing. And then the most obvious and the most renowned product of which comes within the regenerative medicine is the PRP, platelet-rich plasma, which has been used in only from the wider specialties of professionals, including orthopedic surgeons, radiologists, sports physicians, pain consultants, rheumatologists, musculoskeletal radiologists, and wide range of PMR consultants as well. So these are all the products which comes under the umbrella of regenerative medicine and orthobiologics. So there is a growing evidence indicating that regenerative medicine products is favorable treatment compared to musculoskeletal conditions, including the osteoarthritis. And the one thing which has proven, especially in terms of the PRP, the safety aspect of it definitely has been proven. There's about 16 level 1 studies around the PRP showing its safety and efficacy compared to the conservative, compared to the traditional treatments of steroids or hyaluronic acid for that matter. So the evidence is growing. We're seeing a lot of meta-analysis, systemic reviews, and we're seeing level 1 research among these from the knees to the muscle injuries, tendinopathies, and even arthritics of the hip joints. There are a wider range of evidences comparatively. For example, a study here of the osteoarthritis comparing of the hip, comparing the PRP plus hyaluronic acid versus the PRP and hyaluronic acid. So there are different combinations and everything else. So I just wanted to give a brief understanding, but we are here to talk about, I'm here to talk about this role of ultrasound. So where does the ultrasound fit in with all these within the regenerative medicine? So I think my personal perspective of this as a musculoskeletal clinician, I could not work without this. I mean, it starts from the initial consultation, scanning, preliminary scanning and diagnosis. So what I've done is I have got a different, for each application of this, I have put a case study so that you can relate this to your day-to-day clinical practice, and that hopefully that I don't have to convince you that ultrasound is crucial when it comes to application of this regenerative medicine. So the first vital part of the ultrasound where it is really crucial is when it's coming to the preliminary scanning and diagnosis. So it's a twofold. This is the first one is the diagnosis part of it. So the diagnosis, you know, especially with the soft tissues, you want it to be absolutely certain, or when you're treating these, you are injecting or you're treating the right structure. So that could be anywhere from, say, for example, you know, the close proximity structures such as carpal metacarpal joint to the dequarium. So the differential diagnosis is so vital. And then you can easily mimic one another. So the ultrasound kind of helps to differentiate that. And then ultrasound also helps to quantifying the pathology, especially around the tendons. And then you wanted to look at the focal pathologies. You wanted to establish whether there is a complete rupture, that there is a partial intersubstance there. So it will guide you to sort of where this treatment need to be targeted. Ultrasound is crucial to quantify the active inflammation of it. So again, you're not going to get all of this with any other imaging modalities. And then when it comes to the joints, it also will help you to establish the approach, the trajectory to the joint, especially if you've got an osteophyte sitting over in your trajectory. So how can you maneuver around that osteophyte? Or it also helps you to see if there's any effusion within the joint. If there's certainly an effusion, it will help you to sort of aspirate the effusion before you put these regenerative therapy treatments. So preliminary scanning is so crucial. At the same time, we always talk about, I'm sure everybody talks about, it will help to guide injection. At the same time, it also helps when not to inject. I think that's as important as when to inject, and at the same time is as important that when not to inject. I think the next case study hopefully will give you understanding of what I mean by that. So this is a lady, a 56-year-old lady, presented to me in the radiology department with a fourth extensor compartment tenosynovitis. One of my orthopedic colleague surgeons has asked me to inject this lady to calm down the inflammation. In this lady's case, it was in the radiology, so they have asked me to inject the steroid to calm down the inflammation. So she had an initial ultrasound scan, which kind of confirmed the tenosynovitis on this compartment sheet. So I'm just going back into the background of this lady's history, past medical history. She had a fall and a fracture of wrist, and then it was treated with the open reduction internal fixation. And subsequently, about 18 months later to that picture, she developed this dorsal wrist pain, which clinically it presents as a tenosynovitis, and then she had a X-ray, and then she had an ultrasound, which kind of confirms that. And therefore, my orthopedic colleague has asked me to inject for this lady's wrist for tenosynovitis to calm down the inflammation. So this is the people who understands the ultrasound terminology, the short axis view. So the probe is in the transverse plane to the extensor compartment. Here is the extensor fourth compartment, digital tendons, and here is the fluid surrounding that within the tendon sheet, suggesting its inflammation. So if you look at the two images, you would say, yes, it is a tenosynovitis, and you clinically correlate, and therefore it makes sense that putting a steroid injection will help you to calm down. But going further into, I've just scanned with further dorsal distal. What I've noticed is, as you can see here, the metal artifact within that tendon sheet is poking through the tendon sheet, going in here. This is the short axis of the extensor compartment. This is the long axis, and then again you can see this the metal screw poking into the tendon sheet. What is it doing? Let me show you what it is doing. There we go. This is the beauty of it. You're not going to get this with any other imaging modalities. So when you can see when you're performing a dynamic scanning, and then you can clearly see the rubbing of the metal screw over the tendon sheet, which causing the fluid collection and the inflammation. So you tell me if any other modalities would able to give you this kind of evidence of your clinical, your scanning, imaging modalities, finding what is the nature of this problem. So I just have to show this to my colleague, my orthopedic surgeon colleague. Obviously, I didn't have to even let patient have to explain why I'm not inject this lady. She was quite clever to understand what is causing the problem. And then I had to send her back to my orthopedic surgeon colleague. Look, it's no point injecting steroid or injecting PRP or injecting the stem cells. This lady is not, problem is not going to get better unless until you address that mechanical issue of metal poking into the candidate sheet. That was quite an obvious and one even for the orthopedic surgeon say, oh yes, we will address that. So this is the classic example of ultrasound, use of ultrasound in the preliminary scanning, and then also then the diagnostic part, and then also, as I said, when not to inject. We always say, yes, its accuracy is great, 100%. You can inject this way, you can inject that way, you can inject this pathology, that pathology, but it's as crucial to understand when not to inject. I think this example is a classic one to explain you when not to inject. Right, the second part of it. So once you've done the preliminary scanning and the examination part of it, and then you move on to a harvesting station, depending on whether it's a PRP, whether it's a stem cell, BMAC, or a fat aspirant. So I've got an example of PRP here, how the ultrasound will help in harvesting in the PRP. I mean, 95% of the times you tend to manage to venipuncture without the use of ultrasound. But you have when there's 5 to 10% sometimes the elderly people with a bigger body mass index, you struggle. You have to puncture 3-4 times. You have to change 3-4 the PRP tubes and stuff. But those sort of patients, when you have evidence, when you can show the patient, when you can look at the needles within the vein and then drawing the blood, why not use it? I think it makes the patient more comfortable, you are comfortable, whole process is comfortable, and then that's win-win situation. Why would you not use it, especially on a people who struggle to find the veins, or struggling to, if you're injecting a multiple joints of a PRP, then you may need a lot more blood. So it's a better way of injecting, drawing the blood. I think, and as I said, it is again, when you have a scanner in your hands, why not to use it? This is only for the PRP. For example, if you're doing a BMAC, and then we do the if your harvest is from the PSIS, we identify the posterior superior iliac spine with ultrasound, bony landmark, and then the trocar is introduced using ultrasound, and that is for the bone marrow. And when it comes down to the fat harvest, and you again, these are the tiny proportion of patients, and especially some of the patients who comes to have these procedures are extreme athletes. They are fit as anything, and they don't have a massive body fat. So finding about 100 mils of a fat in a athlete or in a really fit person is extremely difficult, even for the plastic surgeon who does the harvest for our procedures. So sometimes you wouldn't believe I have to use my ultrasound probe to find them a pocket of these subcutaneous fat. So that's what I do sometimes, because Suresh, I can do it with your help today. They cannot seem to find, because they are so fit. Those sort of patients, I think ultrasound kind of is a great way of helping during the harvesting phase. So once the harvesting is done, the next step is obviously targeting exactly where these cells or the growth factors needs to go. Okay, it's extremely useful in small muscle phase, partial intrasubstance tendon phase. Okay, when you're injecting a PRP, if you try to inject the PRP in a healthy tissue, it wouldn't take it. And then when you're trying to inject within this tendinopathic or intersubstance tear sort of thing, it's like a sponge. It sucks the PRP. So if you have a partial tendinopathy or the small intersubstance tear, injecting that soft tissue without ultrasound help is highly challenging. Because as I said, you can't inject the PRP into the normal tissue. It will offer you resistance. When you're injecting into tendinopathy, that's where it succeeds. It's so useful having ultrasound to identify that focal pathologies, a focal area of intersubstance, or it could be a tendinosis, or it could be muscle tears. So this, especially the muscle tears, if you have a grade 1, and if you have a hematoma, you take the hematoma off and then inject exactly where it needs to go. I don't think you would be able to do that without the help of a direct visualization of ultrasound. And the small joints, like if we inject tiny IP joints, AC joints, midfoot joints, MTP joints, those are the small joints. Injecting those small joints, the small amount of fluid is a crucial, because end of the day, all these regenerative orthobiologics products are as good as if they are targeted and if they are delivered into exactly where the pathology is. So if you're not achieving that, you might not as well do those procedures, especially when they are very novel and very expensive, and then you are making sure they have to reach exactly where they need to go. So the small joints, you only even put half a mil to 1 mil. So those are the challenges with the small joints. Injecting that small amount of volumes, I think without ultrasound, it's highly again impossible. And the deep joints like hip joints. How many of you inject hip joints in daycare theaters under a fluoro? I think it's, when I started injecting hip joints about 8-9 years ago under ultrasound, everybody has kind of looked at me, look at this crazy guy who is injecting hips in an outpatient clinic under ultrasound. Now, it's a common practice. So the ultrasound is so useful to make the patient journey as comfortable as possible, and especially these joints like hip joints or the spine, facet joints. I do a lot of facet joints. These are all deep joints, and the ultrasound is as good as, when the alternative of fluoro, again, in a good pair of hands. You need to have that experience. You need to have done so many of injections, but it could be as good as injecting under fluoro. The complex structures. I think, a good case study for this complex structures. I'll share that. Again, these complex structures such as iliopsoas tendon, for example. If you're injecting sacroiliac joints, if you're injecting into the complex structures like distal biceps is another one. Even with the ultrasound scan, injecting a distal biceps tendinopathy or distal radiobicipital bursa is extremely challenging, because you have quite a few neurovascular bundle either side approach. And if you are approaching a short axis, lateral or medial, lateral, you have radial nerves, and you have medial, you have a medial nerve, and you have a brachial vessels. So these are the complex soft tissue structures. Or I would recommend ultrasound is impossible to replace. Hi, this is one of my patients. Some of you might recognize him. He's quite a popular bodybuilder from States. What he has done is he was participating. He was training to be a world's strongest man competition. He was training in London. And as a part of the training, he was performing that heavy stone lifts, putting up on the different heights. While he was doing that, what he did, he felt something go. What he has done is he torn his biceps. He came to us within, I think, 3 or 4 days after initial injury. He was in London. He was being recommended by one of our orthopedic surgeons in our clinic, Mr. Rani. And he had a couple of MRIs because he's being a very high performing athlete and a bodybuilder. He's got a huge family following. So everybody wants to be very cautious on how to approach this gentleman's problem. So I don't know if it's fortunate or unfortunate. he had his distal and the proximal attachment, both were intact. Both were intact. But what he managed to do is just as grade 1 to snap of the MT junction of his biceps. That's what he has done. So orthopedics, from an orthopedic surgeon point of view, they were like, look, there isn't anything we could do from surgically, and then where you tone and the amount you tone is very, it will heal on its own, but we cannot operate on it. However, what we could do to help promote that healing, we could send you to Suresh. That's when he came to me. So here it is again, ultrasound image, short axis of the biceps here. And but look at this. This is the biceps muscle towards the elbow. This is them towards the shoulder. Here is the muscular-tendinous junction. Let me show you a video clip, I think. So here it is. So here is a that small grade 1, grade 2 tear of the muscular-tendinous junction of the biceps tendon. So what we did, this guy, look at, he's about almost 5 centimeters depth of biceps, and then look at that subtle tear of biceps. So what we managed to do is put as a fluid in the area of where the torn part is in the muscular tendon. You can see the nice dispersion of fluid going in where the tear is. So these sort of things you cannot do without help of ultrasound, because they are very subtle. And the crucial part is, because they are so subtle, and then you're putting something like, I think we did a PRP on it, putting growth factors which can help to heal the damaged tissue. You've got to be absolutely certain you're injecting in that part of the torn part of the muscle. Okay, and then the next case study on this is this 25-year-old gentleman, 2 years history of chronic patellar tendinopathy. He had an extensive treatment with the physio and shockwave, eccentric loading, etc., etc. Unfortunately, it's not helped his symptoms. So what does the ultrasound show? There you go. So again, predominantly 80% of the tendon was absolutely fine. What he had is just a small focal area. So again, this is so important when it comes to injecting these tiny focal areas. You cannot target those areas without image guidance. I think that's where the ultrasound is so crucial, helping to kind of focusing to that area. That's what the ultrasound does. Right, this is a fairly new one actually. I thought I would just throw this as well because it gives you another prospect of role of ultrasound. So this lady, she had 4 weeks ago lipogems injected. She has been fat harvested from the tummy, and after 4 weeks, what she seems to be developing is quite a nice lump where the fat was taken from her here. So what she developed is a friction injury, is similar to degloving injury like Moral Lavalley. So what happened here is where the harvesting was taken, she had a nice seroma collection between the subcutaneous fat and the fascia. And then you can see it's a compressible, no vascularity, and it's a nice, fluid, no aggressive features, nothing sinister. But that is a complication of following the fat harvest. So what we then, so the ultrasound, the use of ultrasound, this is what I did. And then look at the comparison from before that. So we went into the seroma, and they've been nicely aspirated. There you go. So by end of that, and she was completely, pain-free, and then the lump is disappeared. I think this is another aspect of it, and people will, do not sort of relate that to, how the ultrasound instant. My plastic surgeon colleague, like Suresh, just to have a quick look, there's no sort of any infection or any other abnormalities. It's quite obvious with the presentation could be a seroma kind of a presentation, but in having this ultrasound in the clinic, and we were able to do what we did with this lady, but again, patient was absolutely, brilliant feedback from the patient as well. Right. Right. In terms of that is a sort of short, brief summary of how the ultrasound is so kind of useful from the different part of from the initial consultation to structure, to the complex, to the small joints, to the difficult patient, and then to the what could be done after if any complications arise. So it is playing a vital role within the regenerative medicine, from the consultation to the harvest to the delivery of these growth factors or stem cells to help it. There's a growing evidence, as we've seen, use of ultrasound offers a better patient experience and acceptability, and it's a proven fact. So I'm sure you guys are all, some of you are using ultrasound. Patients will tell you, what is the experience going into theater under fluoro, or then doing it in awake and in an outpatient procedure. So especially when you're using these regenerative therapies, their outcome is directly depending on the whether it's reached to the area, so you get a better outcomes if you target it into where the healing needs to take place, where the regeneration needs to take place. So it won't be effective if it's delivered to the healthy tissues, because there's nothing needs to be changed. So that's so crucial. So you get a better outcomes with better accuracy. That's proven. That's proven in the regenerative. So the one limitation I would say is there's a training aspect of it, and then the experience, practice. It is as we all know, ultrasound is so operator dependent. So it is as good as who's doing it, is as good as the knowledge and the sound anatomy of the person who is using it. And then it's also that experience. You have a constant support in terms of the supervision. You're performing the structures which are more familiar to you, and then you are doing more and more and gaining that experience, getting better at the technique before you're moving on to the challenging structures. But it is getting better. When we learned over 15 years ago, I wish we had so much of online stuff available, or so much of literature. At the moment, you've got so much there. So the learning and the practicing it, and then getting somebody to look at what you do and correct you is crucial. So the learning point of it is so crucial as well. So that's me as a short brief. Now probably will take some questions. Nakim, is that all right?
Very good. Okay. Just I will invite my friend Omar to join us.
Yep, sure.
Question. Mm-hmm. Okay. Okay. Hello, Dr. Omar. Huh?
His mic is mute, I think. Yeah, I think he can hear you now.
Hello.
Hello. Welcome, Dr. Omar.
Hello. Hello.
There is no video camera? Okay. Okay, I will really appreciate your time there, Suresh. But first, I want to welcome dear friend Omar Mabruk. He is faculty member.
Hello, Dr. Omar.
Yeah, and he's also MSK sonographer here in Egypt. So he cannot join us in the beginning, but he will join us in this last event. But I want to ask first question. So regenerative therapy is the big title. Just is an umbrella for extra corporeal shock therapy, PRP, stem cell, ozone, a lot of tools. But a lot of research focused on no superiority for each of the regenerative tools than other. So what about your opinion?
I mean, we were the very first ones to bring this whole stem cell concept to the London, the regenerative clinic. We have been doing this for the last 2 years. We are the very first one, especially the lipogems, the fat harvesting one. At a similar time, we've been doing the PRP as well. So from our own, we've done about 2,000 joints using the lipogems, which is fat derivative mesenchymal territory. From our own experience, we have a research team who collects the data. We've been following 6 weeks, 3 months, 6 months, 9 months, 12 months follow-up. So our first cohort has come to 2 years. We got 80% positive response on a grade 2 to grade 4 arthritis. So we've done from most of 60% of our patient experiences on knees. On top, additional to that, we've done the shoulders, we've done the knees, and we've done the ankles, we've done the hips. We've done the small joints, as I said. So that is for the lipogems, the fat derivative stem cells. I think our data kind of mimics the data out in Europe and also in the States, America. Yes, it is still an evolving technique. I think people are still looking at it more in a skeptical way. But over the last, I would say, last 12 months or so, we're getting more data out on these techniques, and the more promising data coming out. But from our own experience, 80% of positive response. That is the stem cell part of it. Whereas there is PRP, I think the PRP is proven. As I said, there are about 16 level 1 studies. The efficacy, the PRP, superiority of PRP when it comes to the not only the soft tissues and also the arthritis of the joints. Okay, and then it's become my main practice now. Compared to a couple of years, I used to do a lot more of hyaluronic acid, where patients could not have the steroids. Now, the more common practice is patients coming in with the knowledge about this PRP, and then they wanted to trial out before we go on to any other regenerative medicine. So in terms of the ladder of treatment, it starts because there's a cost involved. These are all not covered by the insurance. These patients are paying from their own pockets. So on the bottom, you have a conservative physical therapy, exercises, loading, activity modification, the shock waves, and the acupuncture, all of non-invasive. Then next goes on to the steroids. And then steroids, as we all know, yes, there is some steroids can help people, but we know it's only short-term benefit. There's no long-term. And then moreover, it's not a safety option when you're doing the repeated injections when the elderly people, or even the younger people for the multiple injections is not advisable. So that's where with the limitations. And then the next step after the steroids, you have the hyaluronic acid. The people are been using hyaluronic acid, but now this concept of using your own cells, using your own growth factors. So that's been taken over. That's been really become an attractive proposition for both the clinicians who all want to treat this. Because safety point of it, yeah, it's safe as like anything. So the only risk with this, I mean, I mentioned the risk profile for the regenerative therapies is risk of infection, like any procedural risk, I would say, but risk of no response, because they are paying quite a lot of money for these treatments. So that risk of no response is a highest risk. Because even they're paying about, say, for example, they pay about good 6,000 pounds for a stem cell into one joint in a knee. And if that doesn't, 20%, we know that 20% of people is not helping. So that is the risk they take. So apart from that risk, there is no other risk associated with it. So, and that has become patients who wants to keep hold of their own joints. They don't want it to, now the people, it's so surprising. People doesn't want it to go down the surgical route. The surgical route, they keep it as a last option for them. So if they wanted to try out what are the alternatives for these, regarding this. So we are seeing this growing evidence, and the PRP, there is no doubt about it. Again, there is still certain faculties like sports medicine, people still do not believe it in tendon, especially weight-bearing tendons like patellar tendon, Achilles tendon. I do see that. We still do not know the why the certain tendons are responding and certain tendons are not responding. There is a lot of unknown when it comes to it. This is where we don't know the right composition of these especially the PRP or even in the stem cells. It is a sort of really clinical decision making. When would you choose PRP? When would you choose a BMAC? And when would you choose a fat harvest? So these are all still people are exploring with their own data, their own publications. But it is getting better. But at the same time, I take your point. There is a lot more questions to be answered here.
Yeah, Dr. Robert.
Hello, Doctor. Many thanks for your informative lecture. I want to ask you about can we inject PRP in acute cases?
Acute cases such as?
Of tendinopathy.
Yeah, I mean, tendinopathies, as you know, it's a long haul process, right? And there's somebody who has done quite an extensive rehab, but before they come to me, they would have had a journey of good 18 months or so. So what they start with, as I said, they start with rehab, loading, rest, and all of that, then go on to the shockwave. And so they've all tried that. So I think that is a good practice. So try it in a sort of a non-interventional way before you come to the PRP. Okay. So answering your question as can we use in acute? So the only acute injuries I treat with the PRP is the muscle injuries. So if you have acute muscle injuries where they have an hematomas and where they have, or there is a small intersubstance tears of the tendons, so those are the ones I tend to inject, not like a chronic tendinopathy. So the acute ones like a muscle tears, grade 1, grade 2, I know the grade 1 Achilles, grade 2 Achilles tendon tears. So those are the ones I treat with the PRP. Again, it is to sort of promote that healing, initial healing, and then healing process more than anything.
Many thanks. Many thanks.
You have a question, Dr. Omar,
yep.
in the QA box. You can read it, please.
What?
في أسئلة موجودة في ال Q&A box. حضرتك شايفها؟ ممكن تسألها. Okay. Yeah.
Sorry, Nigam, you asking me?
We have a question, dear Suresh. First,
sure.
question.
Yeah.
Great lecture. So, what patient preparation do you routinely before regenerative injection? This is the first. Do you use topical anesthesia, cryotherapy?
That's a good question, Kenneth. It all depends on the type of regenerative medicine product you're using. For example, if it's a PRP, we do not mix PRP with a local anesthetic. Okay, that is the one aspect of the thing you have to discuss with the patient during your consultation. Some of my colleagues do use the local anesthetic to the subcutaneous tissues, so which prevents the needle entry. But actually, when you're injecting the PRP, the main pain, the main discomfort the patients feel is when the PRP is being delivered into the soft tissue or the PRP being delivered into the joint. So you're not going to sort of prevent that. The only thing, you could do, especially in the lower limbs, especially in the plantar fascia, the midfoot joints, what we tend to do is, I tend to do a block. So I do a tibial block so that they won't feel it. So you can use it that way, but I know there is an evidence that if you use the local anesthetic with the PRP, it's going to damage the growth factor. It's the same application to the regenerative. For the fat harvest, the fat harvest, what we do stem cells, the adipose derivative stem cells, we do them in a theater. So we have the multidisciplinary team. We have an anesthetist, we have a plastic surgeon, and we have a radiology, somebody who's injecting. So anesthetists use the mild to moderate sedation depending on how many joints their patients are having. And then the sedation part is twofold. One is for the harvesting. So even with the harvest, our initial experience, we used to mix the temozolone solution with the local anesthetic. What we noticed, what we learned, using a local anesthetic within to the fat, that will kill the cells, that will damage that is a potent to the pericyte. So what we have done, how we changed our practice rules. So in the solution, we don't use a local anesthetic anymore. So the patient has been given a bit more stronger sedation. We only use a normal saline for the fat to be, in the temozolone solution, and then fat being harvested, and then the patient is given a small dose of sedation before I do the injection. So the local anesthetic does not come in, play in terms of even this is, when you're doing the BMAC, bone marrow harvest, and then you can inject a local solution to the subcutaneous all the way to the bone. But the basic principle is you cannot mix the local anesthetic with the PRP or the stem cells.
Many thanks, Doctor. Another question, is there any role for PRP injection in piriformis syndrome?
Right. In terms of the intramuscular PRP injection, my experience has been, I use this as a last resort, right? I do the trigger point injections. So the patients who's got a chronic problem, and they have tried all sorts of, acupuncture or myofascial release. They've tried, injections of steroids into the trigger points with a small, relief. And those are the patients, and these are the ones they tend to respond really well to the intramuscular PRP. So there is an evidence that these growth factors work at the myofascials, the myocytes level as well. So that was a sort of a theory, the rationale behind using on a chronic. For example, when I do the facet joint injections on spine, I inject into the facet joints and then come off, and I also inject in the paraspinal muscle. So that seems to be helping to either to calm down the muscle spindles or get rid of the spasms, get rid of their the trigger point tenderness. But yeah, if it's a chronic one, if it's responded partially to the steroid injections but not got a long-term effect, then I would encourage them to use the PRP. The one thing you got to be absolutely reassured from is safety. So it is safe to inject. It's not going to cause any damage, but in a long-term chronic myofascial test, I would use.
Many thanks, Doctor.
Okay. Any other question, Dr. Omar?
Last question, I would like, Doctor, you prefer in-plane technique or out-plane technique in the injection?
Yeah, so I am one of those guys who always, if I can do it, always do in plane. The only out of planes I do, even I do pubic symphysis in plane. So that's me. That's my way of the technique wise of doing was. But there is a role for out of plane as well. If you're injecting a tiny MCP joints and the IP joints. And then it's quite easy, but you got to be absolutely make sure what you're seeing on your screen is the bevel of the needle. What I mean by bevel of the needle is not the shaft, and you're seeing something, and your bevel of the needle is somewhere else. So that is the one thing I would reassure every clinician before when they use the out of plane technique, making sure they see the bevel of the needle rather than the shaft of the needle. But my preferred approach, if I can get away with it, I use in-plane technique every time.
Okay, please, Dr. Omar, what about the number of times that you inject PRP in mostly about different cases?
Right.
First, and the second one, what about the interval between each?
Interval, I see. Yeah. Right, that's a good question. There isn't any consensus on the course of injection so far. Some studies have used one-off injections, some studies have used course of 4, some studies have used course of 6. So there isn't any sort of consensus. But however, what we've been using, what is the standard practice across the globe, is course of 3 injections. If it's intra-articular or if it's in soft tissue, it's a course of 3 injections. There are some exceptions where you can use a one-off. It also comes down to the financial aspect of it. Sometimes there's a grade 1 lesions or mild partial disruption of the tendons or muscle fibers. You can use one-off and see how does it respond to it. But overall, as a general concept, you use a course of 3 injections. If it's intra-articular, I tend to keep it a week apart, because you've got to understand these 10% of these PRP injections have a flare-up. When I say a flare-up, the joints are a bit swollen, bit painful, bit achy following the injection. Sometimes that flare-up can last anywhere from 2 days up to a week. So if that flare-up lasts up to a week, then I bring them 2 weeks apart rather than a week apart. For the intra substance, like a soft tissue, like tennis elbows or tendons, or the bursas, they tend to cause more discomfort. So for the, as a rule of thumb, I tend to keep it intra-articular a week apart, and then soft tissue as a 2 weeks apart between the injections. But again, you can leave it 3 weeks or 4 weeks. Again, there isn't any sort of data on any efficacy if you leave it for 2 weeks or 3 weeks. But all the logistics, the patient can come or patient has a flare up. But yes, that's a 3 in terms of number of injections, and then the time interval is a week to 2 weeks between.
Okay, Dr. Amr. Dr. Amr.
Doctor.
You can end this session, yeah?
What?
Yeah.
Connection is unstable.
Okay. Dear Dr. Suresh, I really, I'm very enjoyed this talk and this amazing informations. I want to thank you for your grateful times and your appreciate your effort. Thanks again. I hope you again and again visit Egypt after this lockdown finished soon. Thank you again, dear Suresh. Bye-bye.
Thank you, Nick. Thanks for your invitation. Thank you, guys. Hope you enjoyed it. Thank you.
Dr. Amr. Thank you, Dr. Amr.
Bye.
Bye-bye.
Thank you, Emma. Bye. Thank you.